and welcome back to Season 5 of the Lighting Your Way podcast. My name is Betty Long, and I am your host during these conversations. I do hope that you enjoy them, and I look forward to hearing your feedback. In this week's episode, I talk with two of my Guardian Nurses colleagues, Rebecca Zarkowski and Megan Swider, both of whom have had recent personal experiences with loved ones needing care at the end of their lives. Palliative care, the topic we discuss, is a resource for anyone living with a serious illness such as heart failure, COPD, cancer, dementia, Parkinson's disease, and many others. Palliative care can be helpful at any stage of illness and is best provided soon after a person is diagnosed. As nurses, Rebecca and Meg share their stories and, as you'll hear, encourage people in similar situations to ask about palliative care. Rebecca Zarkowski and Megan Swider, welcome to the Lighting Your Way podcast.
Thank you, Betty.
Thank you. Thanks for having us.
Yeah, you guys are veterans of the podcast. Both of you have been on before, so I am looking forward to having this discussion about palliative care, which still is sort of an unknown in the healthcare system, despite its best attempts to educate folks, including clinicians. It still remains kind of a secret, and no one really understands. I shouldn't say no one. A lot of folks don't understand what it is. So we're here because, Rebecca, you had a dear friend who was also on a podcast in December, Renee Pedro, who was going through her own healthcare challenges with stage 4 cancer. And she died last month. And Meg, you had a mom who was also on palliative care, and who also then transitioned to hospice and died. So, Rebecca, I want to give you the stage. Tell us about those last couple of months with Renee.
Yep. Thanks, Betty. So, Renee and I, throughout from July of 22 on, when her diagnosis became more progressed and the outcome more real, she and I had lots of conversations about what it's going to look like. How is she going to feel? What's it going to look like for her and her husband? And one of my asks in July was that she consider, this was not the first time we had the conversation, but we consider adding palliative care to our care team, because I was hopeful that palliative would have been involved early on, because I feel like they are the unsung heroes when you're talking particularly about diseases that progress to end stage like cancer or COPD or heart, CHF, all those chronic diseases that over time will wear and tear at your body and eventually potentially could be your end of life. And palliative care, in my experience professionally, has always been kind of the quarterback of the oncology team. My background's in oncology, so I'm only going to speak about that. And they were really the background or the quarterback as a primary care physician, pain management, and also identifying if there's resources outside of the oncology team that are being missed that would help the patient and their caregivers with this difficult journey. And the earlier my experience has been that we engage palliative care, a couple things happen. One, it provides good education for the patient and the caregivers. And it's usually topics that the providers and the care team don't always address proactively, but they're real concerns and they're real life events that happen when you receive an oncology diagnosis. And so in July, I had discussed with Renee a couple of times about bringing them on board, not even so much for Renee because she was really against it. She viewed palliative as giving up. So she viewed palliative care and hospice care as the same. Okay. And that would have translated in her mind to feeling as though she was giving up. I asked her if it was okay for me to speak with her care team. She said yes, and I did speak with them, and they did tell me that they had recommended palliative care a couple times and gave Renee the number, and she wasn't ready yet, and they were going to essentially meet her where she's at.
Okay.
And so when she was on last time in December, she had just been discharged, and we were discharged at that time with palliative care, but notice that that's just a couple months before she passed away. And so the benefit of having a strong palliative team on board was kind of lost because she was really nearing where hospice would have been appropriate, not palliative, because palliative is not end of life, right?
Right.
Hospice is end of life. And that is the big misunderstanding or lack of communication between care teams and patients. And
did
that
the
lack of communication.
Right. The lack of communication, that's what I'm picking up on, is that, even though she was with an oncology team throughout her 6 years, as she progressed as her disease progressed, they did bring up palliative care, but she was against it because in her head, it was hospice and it was giving up.
Yeah. That was 5.5 years into her diagnosis.
Wow. And do you feel like it would have been beneficial for them to have brought it up sooner with Renee?
Yeah. So it's funny. My experience where I came from, my oncology background, palliative care was part of the initial care team that our patients met.
Oh.
So they would meet the oncology team. If you needed a rad-onc, they would be included, nutrition, palliative care, Reiki, massage, like all comorbidities involved in the actual development of the treatment plan. So on day one, these patients and their families were meeting the palliative care physicians, and it wasn't scary, right? Because we were able to say to them, this person is going to fill a hole for your primary care needs, your pain management needs, and be able to assess if we're missing anything else. It was never, this is an extension of hospice, because we weren't talking about discussing end of life. We were discussing the journey and the importance of having that resource there. And it was not, most places do not discuss that from go.
And why do you think that is?
I don't know. I don't know if it's, and Meg, you can weigh in on this. I try and understand, is it discomfort with the conversation? Is it, I don't know, is it benefit coverage? Is it not covered? I don't really know why we wait until someone is so sick that they automatically, hospice and palliative are like one bubble because of when it's introduced. But they're not one. Not one.
So,
right, I agree. I think people think it's synonymous. Palliative goes right into hospice care, which in all cases, that's not true.
Okay.
And I think it's just the distinction. People, they just automatically think palliative and then it's going to go into hospice.
Right.
Because I know my situation was a little different.
Well, yeah, your mom had congestive heart failure, and that, as
Correct.
Rebecca said, it is a progressive disease, and your mom was in her 80s. So did her clinical team offer palliative care, or was it something that you?
That's something that I initiated. The thing with my mom, like, you're correct, she had congestive heart failure, which is a progression of a chronic disease. So believe it or not, before she passed away in May, so the year before she got very sick and she was in the hospital and she was not doing well at all. And then, as the days went by, she was getting a little bit stronger, but still not out of the woods yet. And I asked for a consult for palliative care. And that's how it started with us. So then we had a physician come up and talk to myself and my family and discuss what palliative care and what resources and how they were going to help. So the way they explained it, they were going to help her more with her symptoms at that time. And they brought, I got a phone call from the palliative doctor. We had somebody come out and do a consult. And for us, luckily, my mom did very well. She bounced back into the following year when, I guess, the end of April, when her symptoms got even worse.
Okay.
And then again, palliative was consulted because they were already consulted the year prior or the summer prior. So then it was easy for them to consult them again. So that's how it worked with our family.
Well, and to both of you, I mean, if you're both nurses, so what does a family do who doesn't have someone clinical or even knowledgeable that palliative care exists? Because if the healthcare system and the healthcare providers aren't offering it as another arrow in the quiver, then how are folks going to engage and ask? Like, right? You guys are both nurses.
Mm-hmm. Yeah, exactly. I think it's word of mouth, talking to each other, doing podcasts, Betty, letting everybody know that, this service does exist. It is out there.
And it is, to Rebecca's point, it is covered by insurance, right? A lot of people don't think, sometimes benefit, I can't believe it, but sometimes hospice care is not covered by folks' benefits. But I imagine that palliative care is, because it's symptom management and thus, if effective, would keep someone out of the hospital, thus reducing costs. So I can't imagine an insurance company being against it. But to both of your points, is it just for the dying though? It doesn't sound like it, because because your mom bounced back, and
right.
Rebecca, if Renee had accepted it, prior, or if the provider had offered it at diagnosis, it would have been kind of an ongoing support for her, which was years.
For me, that's the one thing with palliative care, it could be at any stage of the seriousness of the illness. But the one thing with palliative, it's also provided with the a curative treatment, I guess, in mind.
Okay.
They can bounce back. In our situation, like I said, my mom did bounce back with, as she went along with her treatment, and she had months and months of doing well. But then again, with, as we all know, congestive heart failure goes through different stages. So then we were able to discontinue the palliative because we felt like she was doing well. We were able to help her manage her symptoms at home and with her physicians. But then when she got to that point again, when her symptoms were, had to be much more manageable with her shortness of breath, with her fluid, we were able to call palliative back in again.
Okay.
And that's the nice thing about it.
Yeah. And Rebecca, your longing for it with Renee could have perhaps enhanced, right, her life and improved her quality of life until she did reach the end of her life with hospice.
Correct.
For the organization that you were part of years ago to have done that right up front is much more effective for families to wrap their head around the idea.
Yeah.
I've heard palliative care described as the bridge, right? There's a bridge program.
Yep.
So you are acute clinically, your acute clinical needs, and you're increasing symptoms, whether it's nausea or it's pain, something. And then they bring in palliative care. And it's interesting to me that trying to get the point across to a patient or their families what this program is, I think providers need to know what it is, because I think actually a lot of providers might think that it's sort of like hospice care. Do you agree?
Right. Yes. And I think a lot of doctors are uncomfortable themselves with the conversation. Because if think about it from a provider's perspective, right, or a clinician, like we're supposed to fix things. We're supposed to make everything okay. People come to us to make it all right, make them healthy. And every once in a while, there's going to be times where that's not, after a certain period of time, you're done, right? Like there's no more fixing anything. And so it could be, I always try and think of why is there this barrier? Why do people shy away from the conversation? Why don't they push harder immediately from diagnosis to ensure the patient and their loved ones that this is okay, it's safe? I'm not by any means recommending palliative and telling you, just to give in to death. That is not what it is. And until they become more comfortable, the providers and nurses become more comfortable with the conversation, I believe it's best suited for people in palliative and hospice, because it's a very normal conversation. And it's not always heavy and sad either, right? Like sometimes patients, I hate to say this, it's a relief. A lot of patients fight for the people that they love. They're exhausted and they want permission to be exhausted and know that they're not letting people down. And so like for Renee, it was very much, she didn't want anyone to think she was quitting. And she had lots of people in her life where you'd have to start from scratch with educating them that this isn't right. And she's tired, and having those conversations with people felt daunting to her.
Okay. Well, that makes sense.
I also feel like it's an extra level of support too. Even as nurses, I don't know if you can speak to this, Rebecca, just, as nurses, everybody comes to us for the answers and questions, but just having, another level of support there, to somebody to speak, on behalf of, even myself, like, and explain it to my family members. This is what we're doing, and this is how, because, I wanted to be the daughter too at times. Because I was grieving.
That's a good point.
I was grieving as much as my siblings were, but being the nurse, you have to be the expert. You're trying to be strong and try to be there to answer the question. So it was supportive to myself. Also, I can say.
Who did you get that support from, Meg? What was it? The nurse practitioner who offered you the support? Okay.
There was a nurse that came, and she came out in the beginning probably 2 to 3 times a week, and we would just have conversations and where my mom was at. I would pick her brain, what she thought about her diagnosis, and she was actually the nurse. And luckily, the weird thing is the palliative nurse who originally came, she was the one that came the second time around. So she was very familiar with my mother. That was nice too.
That's great.
So yes, and she's the one who actually made the transition from palliative to hospice a lot easier for us. Like I said, I don't know if it happens that way, but we were lucky in the sense that she knew my mom from the summer before.
So at a certain point, she assessed your mom and thought, okay, we can, we've been tweaking meds and we've been tweaking this, but now the heart, her heart is not going to respond to other meds. So we need to look at it different. Okay.
Yeah. And my mom was a fighter, believe me. She was like that. We didn't know when to let her give up, because she was such a fighter. Like she would try to get up, and just watching her try to walk up the steps, it was just heartbreaking, but she was just a fighter in herself. So she was there to help us talk to my mom and, let her make that transition also.
I think it's an important point that you brought out, Meg, that you as the nurse and the daughter, right? You wanted to be the daughter and not the nurse. And especially in your situation with a large family, everybody's coming to you. Rebecca, did you have that experience with Renee and her family?
So, yeah, I mean, yeah, so we're so intertwined. My family, her family, friends, her friends, our friends, Bo's family. Yes. And I have to be honest, like during it all, I remember the day that I talked to you, Meg, and I can't really remember like when it was, but it was certainly after her discharge in December, but before January. And I remember being so upset because it was a day where I was taking a lot of calls and answering a lot of questions. I can't even remember like what happened, but it was scary time.
We were in a conference room. We were at Guardian Nurses conference room. I remember that conversation.
You do? Thanks.
Yes.
And
yes.
I used Meg. I mean, I felt like I didn't have anybody in that moment who could possibly understand that, like, I was sad, but I felt like I needed to hold it together to help all these people that love Renee as much as I do, right? And I have this education and understanding, and it wasn't time for me to worry about necessarily me. I do remember saying to Meg, like, if she would just agree to palliative, it would be so helpful to me and Bo. Like, I almost was like, forget you, Renee, I need it.
Right.
You know, because I really could have used it. I had a lot of questions about the way they were managing her or not managing pain, because it, you know, had just gotten so bad and so progressive. And that's yet, you know, she had pain management on board. She had a pain management on board, but that palliative piece is just different. It just manages things a little differently. And
I believe palliative is just a little bit more personable than if you had a pain management and all your separate specialists. I believe palliative, and that's one good thing about palliative, they can work with your own doctors. So they incorporate, you know, all the specialties together. That's what's nice about it.
I look at them like, you know, I always use a lot of baseball analogies, but I think of them as the free agents, right? They can pop in, right? They're specialists on on symptom management, really. So, you know, while we have orthopedic surgeons and they, you know, subspecialty is hips and knees, and then we have cardiacs, and everybody's got a subspecialty. These are typically internal medicine or these are primary care doctors, right? Or other physicians that come into the specialty because they want to focus on symptom management, and they have tricks in their bag that other doctors may not have. But they're what I appreciate about palliative care physicians is that they're always willing to work with other physicians, right? They're, you know, like sometimes the silos go up when you're dealing with other specialties. And in palliative care, it's not. It's like very open. You know, we're here, believe it or not, we're here for the best outcome for the patient. And they keep that, I think, front of mind.
Yeah, real quick, one story that relates to that. It was a Saturday afternoon, and we were trying to get a pain medicine for my mom. And, you know, it's hard to get in touch with the physician. So I reached out to the palliative nurse, and she said, "Oh, I will take care of that." She said, "We will get that medicine." And it was, you know, that night we were able to get the medicine. So that's, you know, it's doing those exhaustive, you know, I know I'm a nurse advocate, but like I said, being, you know, the daughter, I wanted to be the daughter, and I was able to reach out to the nurse, and she had no qualms about it. "Oh no, we will get that for her. I will reach out to her." So
Doesn't that feel, that must have felt great for you, Meg, because you're always doing that for everybody else.
Yeah.
That's great.
So
that trust
one
someone.
definitely. Yes, exactly. And she made it happen. She came through.
That's great.
You know what she promised, and she came through with it.
So, Rebecca, when you think back, would you have done anything differently to persuade Renee to engage palliative? What would you do?
So I would have requested it when it was a DCIS diagnosis, which obviously should be a good prognosis. And from go, I would have had palliative introduced. I would have asked for the referral. I should have been more thoughtful, you know, 2020 backwards vision, right? Monday morning quarterback.
Right.
because she could have said no then too, and probably would have, but I would have been in a much better place to barter and say, listen, could you just hear what they have to say? That's all, just hear them out. And she would have been in 2015, she would have heard them out.
Okay.
But as each year went on and the prognosis got worse, it became scarier and scarier because she thought it meant the end of her life.
Okay. Mm-hmm. So what would you, I think I know where this is going, but what would you like to say to folks who are listening who may be in a situation where there is a new diagnosis that's life-threatening, or a chronic diagnosis that's getting worse? What would you like to say as a suggestion to folks?
Well, me personally, I would say trust your doctor. Have these conversations with the doctors that you trust. I'm sure if you bring up palliative and just ask the questions and how can they help, start there. Just start with the conversation, bring in the word palliative up. And they can, always do a consult. And just that consult, you're just there to listen. There's no guarantees. You're not bound to anything. It's not like you sign a piece of paper and you're stuck in something. It's not like that.
Okay.
Just listen. Mm-hmm.
Okay. Rebecca, how about you?
So I'll piggyback off of that and suggest that people who are listening to this podcast, maybe they could Google, believe it or not, everything I need to know about palliative care. And you'll get TED Talks, you'll get podcasts, and you'll get wonderful articles. And I think the first thing people need to do, don't listen to us, do your own research.
Okay.
Mm-hmm.
So that when you do go speak to the provider, you're educated in what you're asking. It's not just off of listening to Megan, you and I say it's a good idea, but go in there really understanding what it is you're asking for. There's lots of good information out there, and it will hopefully get rid of the stigma and the fear that comes along with palliative.
Great. Yeah, it's a great suggestion. Piggybacking off of those suggestions, Meg and Rebecca, I'd also like to say to folks who are listening or maybe going through this, to actually ask in facilities, if you're being diagnosed with cancer or something, whether they have a palliative care team. Because not all facilities may have a team that specializes in palliative care. So I think that's an important distinction as well. Ladies, thank you very much for your time. And Rebecca, I'm sorry again for your loss. And Meg, sorry for losing Mom.
Yeah, thank you for bringing this to light. I think it's important for people to, know what palliative care is.
Always. Okay. Thanks, gals.
It may help them. Thank you, Betty.
Thanks, Betty.
All right. Take care.
Okay.
Bye-bye.
Bye-bye.
If you would like to learn more about palliative care, as Rebecca said, there is plenty of information available on the internet, but one site to start at is getpalliativecare.org. GetPalliativecare.org. If you have any questions that you would like us to address in a future episode, please email us at podcast@guardiannurses.com. That email again is podcast@guardiannurses.com. We would love to hear from you. Thank you for joining us this week. You can find the Lighting Your Way podcast on Apple Podcasts, Google, YouTube, Spotify, and Stitcher. If you liked what you heard, tell a friend and leave us a review. You can learn all about Guardian Nurses Healthcare Advocates on our website, guardiannurses.com. So until next time, find some joy in your life, pet all the good doggies and kitties, and remember to tell your people that you love them.